All right. Well, hello, everyone. We are going to go ahead and get started. Thank you all for joining us on this Friday afternoon. Welcome to the PFCC Partners Monthly Workshop. I am Lindsay Galley. I'm the Director of Education for PFCC Partners and facilitate all of our workshops. I'm really excited about our workshop this month because we are going to be introducing the Diversity, Equity, and Inclusion Work Group's recent environmental scan. This recently developed work group is partnering to set the table for equity in healthcare and beyond. We actually just got off of a work group meeting where we are having such rich discussions about our vision and our purpose and the focus for the work group. I'm really excited that today we will be joined by DEI work group members and also stellar patient family advisors David White and Naomi Williams. David White actually may or may not join us today. He had a conflict, but we are very excited to have Naomi Williams with us to represent the work group. We are also joined by Janice Tufte, who is a patient family advisor, and Anna Capito, who is a research associate at the National Academy of Medicine, who partnered to develop the National Academy of Medicine's publication, Patient Family Engaged Care, an Essential Element of Health Equity. We are using Zoom. If you are unfamiliar with Zoom or this is one of your first times on a Zoom meeting, there are a couple of things just to be aware of as we move through our meeting today. We will have plenty of time for questions and answers at the end of our session. So if you have any questions that come up as the presenters are speaking, you can go ahead and put those in the chat box. And the chat box and everything else that you need is located on a little toolbar. So if you're using your computer and you hover over your screen, you should find a toolbar that you can locate the chat box on. You can also find the mute button. So if you have some background noise, you can turn off your microphone, and then you can also turn it back on during our Q&A if you would like to speak up and ask questions. I see a lot of familiar friendly faces, so thanks all for using your videos. Always great to see people in this time of not in person seeing people. During our Q&A as well, if you would like to come off mute, you can find a raise hand button. So if you hover over your screen on your computer, there should be a participants button and you can click raise hand there. It should be a little blue raise hand, and Laura, who is our host for the meeting today, will be able to let us know that you would like to come off mute, and she can help get you off mute. And then if you have any questions about using Zoom or any issues connecting, you can put those in the chat box and Laura or myself can help get you connected. Okay, so before our workshop today, we asked everyone in the registration, what are you doing to improve health equity? Here are a few of the responses that we saw on that kind of poll entering in question, and I really encourage all of you to chat in what you, your organization, or your communities are doing to create a more equitable healthcare system, or just helping to improve equity in general. I would love to see some more responses in the chat if you've had new ideas or done new activities to really help improve that overall. In the responses that we did get, we saw very specific examples like equipping Black women with data skills to carry out their mission in public health, to general responses like everything, all that I can, educating myself, and listening and learning. PFCC Partners, our organization, has been on a listening and learning journey over the last couple of months ourselves, and are really grateful for every opportunity that we have to do so, specifically our partnership with the Diversity, Equity, and Inclusion Work Group. And our organization, PFCC Partners, is a patient-driven organization. We all serve in the role of patient family advisor, anywhere to our local hospitals and health systems to national partnerships. We utilize those experiences as patient-family advisors to support the partnership of healthcare providers and patients and families, because we really know that the best possible health outcomes happen there. And PFCC Partners is the organization that fully supports the Patient Family Advisor Network, or the PFA network. The PFA network's mission is to create a network of thoughtful and prepared patient and family advisors grounded in authentic partnership approach to co-design policies, research, and care delivery. The PFA network meets its mission by bringing together patient-family advisors through monthly virtual meetings, provide skills exchange opportunities, and connect patient-family advisors to engagement opportunities as well. Through these avenues, the PFA network also provides a platform for patient-family advisors to identify current challenges to partnerships in healthcare. And those challenges are formed by work groups. So work groups are formed, which are led by patient-family advisors all across the country. And they're formed to address challenges that arise in the PFA network. Past challenges have been patient access, have been the opioid epidemic or opioid use disorder, and compensation for patient-family advisors as well. Work group members brainstorm creative ways to influence the specific healthcare topic chosen. Outcome products are then generated by the members to amplify the perspective of patient and family caregivers. Each work group starts with an environmental scan in order to recognize a gap that the members can partner with to meet the current needs in healthcare. And that is no different for the diversity, equity, and inclusion work group, which will be shared with you today. We really want to start by thanking each of the DEI work group members for the incredibly powerful and open discussions that we have had over the last couple of months. I had mentioned this earlier, we just got off of a call as well, and the work group is in the final stages of developing the vision statement, which really includes a focus of global and local community empowerment, education, and supporting uncomfortable conversations. And with that, I think I am going to pass it over to Naomi Williams, because I'm not seeing Dave with us today. So I'll take a moment to introduce Naomi Williams, who is a patient family advisor and a member of the Diversity, Equity, and Inclusion Work Group. Naomi is going to talk a little bit about, or provide some definitions of diversity, equity, and inclusion, and introduce the environmental scan that the work group has produced and will continue to produce, as well as a few resources identified on the environmental scan that really resonate with Naomi as well. So, Naomi?
Great. Thank you so much, Lindsay. Good afternoon, everyone, and greetings from Augusta, Georgia. I come to you from Augusta University Medical Center and part of PFCC Partners Diversity, Equity, and Inclusion Work Group. Was very interested when Libby had put out the call for this work group, and knowing that diversity, equity, and inclusion is not only geared towards African Americans or the Black community, but that's where we are starting based off of where, can't even see just the need, but where we are as a country. And Libby and team looked at what are we doing, we being PFCC partners, what does it look like for us? And knowing with this work, there is a lot of adaptability and flexibility. So Dave and I are working with our definitions. Here we go. So looking at diversity, knowing that having a variety, who is at the table. The other part to this is looking at equity. So the first definition, as you can read it here, talks about justice according to natural law or right, but specifically looking at freedom from bias or favoritism. Freedom from bias really stands out to me because we all have biases. So part of that is learning what are our biases, We have conscious and unconscious biases. So being aware of those and knowing how that impacts how we work with others, our frames of minds. If you'll go to the next slide, please. So looking at, Dave pulled this slide and it speaks volumes. I'm not going to read it to you because you all can read, but there are certain things that stand out for me and with the group. So when you talk about broadening the definitions through inclusion, it's not looking at the flaws, but wanting to look at how do we look at the benefits of inclusion? What are we bringing to the table? What are the plus sizes if we are operating equitably across the board? If everyone has not just an equal opportunity, but there is no bias, there is no favoritism when they come into our doors or when we go into the community. Talking about different, not even just race, but looking at religion, gender, ability, disability, age, experiences, and perspective. We all have our own lived experiences. Even within the work group, we have challenging conversations. And that's a good thing because we all have different experiences. And we're able to learn and grow with each other from that. So part of this work, when you talk about diversity, equity, and inclusion, excuse me, a lot of this involves being vulnerable, transparent, and willing to have uncomfortable conversations. It's worth having an uncomfortable conversation because that's where growth can begin. It's worth fighting for. And it brings joy in the end. If you'll go to the next slide. You can see Deborah Perez, that was her quote, but looking at the joys of inclusion. So with this work group, we started with an environmental scan. One of the things I greatly appreciated from Libby was in reaching out to the African Americans in the group and being able to say, I don't want you, it's not your responsibility to teach us, but can you help us? So we put together an environmental scan. So basically looking at the resources that could help educate of how did we get here? Why are we here? How do we make a difference? This is not it's a living document, so always adding and changing. We invite you, there is a link here, and I think Lindsay can put it in the chat. You can review it. If there are things to add to it, we highly recommend send that to Lindsay or to Libby so it can be added. But it's a way to find out where are we and how did we get here from various, I'm gonna say groups, I want to say different populations, but it is different populations, different groups throughout the country as well. So if you go to the next one. So there are two specifically that spoke to me that I want to take you through briefly. One of them is medical apartheid. It was recently updated. This is the old version, if you will. But looking at medical apartheid takes you through the dark history of medical experimentation. So looking at why are African Americans reluctant. Sometimes we use the word, in healthcare, we use the word non-compliant. It's not a word I like because for us, healthcare is often non-compliant. But looking at why are African Americans, why does that population tend to be reluctant to medical care, reluctant with vaccination or I don't want to say experimentation, with vaccinations. We're in the time of COVID and going through clinical trials. And it's hard to get people who look like me to participate because of the history. And so a lot of this is being able to understand the narrative. Narrative controls a lot of what is done. So I'm in my 40s. I haven't lived through the 60s, didn't live through slavery, but I have heard and have learned. And the narrative, what I learned in school, is not the narrative that has come from my family. There's two different stories being told. So medical apartheid gives insight to what were some of the atrocities that have been done. One of the things that is well known is of the Tuskegee syphilis study, and that was done through the government all the way up through 1972. So why is there reluctance? So this book is for me is a good read to understand the history and to understand where African Americans are potentially coming from, and why there's a need for, say, this week is this month is National Breastfeeding Month. This week is Black Breastfeeding Week. Why is there a need for Black Breastfeeding Week? Well, back in the day, Black women were wet nurses. They would feed their master's children, and their children would go without. And that goes through history, that gets passed down, that trauma perpetuates through the system. So now there's a push to educate and to have Black women breastfeed their babies. The other picture that's here is there's an organization called 15 White Coats. And this is a picture of 15 medical students standing in front of a former slave quarter. And it's powerful because at one point in time, not only were they not allowed to go to school, they couldn't read, they were considered property. So being able to understand the narrative so you can begin to have those uncomfortable conversations to where we can have true diversity, equity, and inclusion. If you'll go to the next slide. The other part, or the other book that has spoken to me most recently is called The Color of Law. And you may even be able to listen to these on audiobooks. I started The Color of Law as an audiobook, and I had to order it because I was missing so much good content. I like to be able to mark up my books. So you may say, Naomi, well, how does The Color of Law, how do laws, what does that have to do with medicine? Well, being able to understand, again, how laws were made, where people live, the conditions that they're in impacts healthcare. So let me bring it most recent, or more futuristic, if you will. Think of Flint, Michigan, and what happened with their water crisis. They knew, people in leadership knew that there was lead in those pipes and going into those homes, those housing developments. But they didn't want to pay what it was going to cost to restore it. And so now you have all of these families and children that are being exposed to lead. And what are the impacts of lead poisoning? So again, looking at what the narrative is, we get bits and pieces of the story. So being able to understand our history allows us to frame the story that is inclusive of all people, and being able to understand why some are reluctant, why some are non-compliant. So as an advisor, how does this impact you? Again, you may not have the medical expertise. You may not know the medical jargon. And we talk a lot in jargon, we talk a lot in acronyms, but you know your experience, you know your history, you are the expert of you. And being at the table helps to give a different perspective It helps to give additional insight. It helps to give a different lived experience to potentially to those that are sitting at the table. One of the great things about our work group, we have discussed, well, how do we get this information out to others? How do we get more seats? Because sometimes there's one or two, but how do we get more seats to the table? And Libby and team, they said, well, why can't we make our own table? And that's what this work group is about. So being able to create your own table and bring people to the table and being able to have those uncomfortable conversations. And I will say, if it makes you uncomfortable, ask why. For those who may say, well, I don't see color, I want you to see color, because color dictates a lot of things. If we don't see color, then why is it on applications? Why is it on my medical history? Why is that? It is important, but my color shouldn't determine the treatment that is received. Next one, that might be my only one.
Yeah, thank you so much, Naomi. I really appreciate just how, especially with the color of law, having that connected to healthcare. And we had talked yesterday, and in such a meaningful way. I mean, you gave me chills when you were connecting it to where people live and why they live there, and that is directly related to the healthcare that they receive and their health outcomes. And so I just really appreciate your perspective on each of these resources and sharing that with all of us. And for those of you wondering where you can access these, Laura did put in the link of the environmental scan in the chat box. So if you click there, you can find both of these links to where you can buy both of these, as well as all of the other resources that have been gathered by the work group as well. Another one being the National Academy of Medicine's Person Family Engaged Care, the an essential part of health equity. So I'm very excited to first introduce Anna Capito, who is from the National Academy of Medicine, and Janice Tufte, who is a patient family advisor who partnered on this publication as well. So they're going to talk a little bit about the publication, and then we'll come back around for questions and answers for either Naomi or Anna and Janice. So Anna?
Great. Hi, everyone. As Lindsay said, my name is Anna. I'm an Associate Program Officer at the NAM, and I'm really excited to be here and presenting with Janice and able to share more information with you about this resource and about some of the work that's currently underway at the NAM to support overall health system-wide transformation with the goal of increasing diversity, equity, and inclusion. We could go to the next slide. So my work is part of the Leadership Consortium at the NAM. The Leadership Consortium is a small group within the larger organization, and we work on transforming the healthcare system in order to achieve a learning health system that has as its end goal improved health, better value, and health equity. So we've organized our action across 4 different domains, thinking about evidence generation, digital health, healthcare financing, and culture and inclusiveness. And we realized that there are elements of equity that are deeply embedded in each of those 4 domains. So we do this work by producing shorter journal-length articles, such as the one we'll be discussing today, as well as longer book-length publications that are similar to some of the consensus reports that you might be familiar with, such as Communities in Action or Unequal Treatment. Next slide. And so the publication that we're talking about today has its roots in an earlier paper that was published in 2017. And this paper was drawing on both the scientific evidence and the lived experiences of patients, their care partners, practitioners, and leaders. And this group brought together 25 individuals who worked over 17 months to create this framework that really looks at identifying the key elements and factors that consistently has emerged as essential to maintaining and creating a system of patient family engaged care, and then organizing those tools into a framework. So next slide. However, The issue of health equity wasn't addressed as explicitly as it could have been in that 2017 publication. And so this work was led by a previous NAM staff member, Michelle Johnston-Fleece, who's now at PCORI. She and the other authors wanted to address this topic in a standalone paper that would allow the authors to dive more deeply into the issues and to really make the link between being truly patient and family engaged in care provision meant listening to a diverse group of patient partners. So this paper is really trying to answer the question, how can we work to improve a healthcare system that's historically contributed to the health inequities that we're seeing now, and try and transform that system so that it can better serve the patients who are showing up at the doors of the system with conditions that are created by those inequities. And so with that, I'll turn it over to Janice.
Should we advance the slide?
Yeah, you can just tell me next slide whenever you're ready.
I'm sorry, did you want me to go now? I wasn't sure. So basically, hi, thank you everybody. This was a long journey. It was longer than 17 months for the initial paper. I just want to add the initial paper. Libby had been a part of that as well. And it actually was the second most read paper that year in that department. And so patient and family engagement was really kind of of great interest. Of course, during COVID, when this came out, we talked about, is this the best time to put this paper out? But we felt it was, considering all the issues around racism and current discord at multi-level. So one of the toughest things we had was actually coming to terms with definitions, and we worked on this for an extended amount of time and switch different definitions. But if you have an opportunity to read the paper, feel free to pluck off one of our definitions or find your own. So next slide, please. So something very important, I'm not sure how many of you have co-written a paper. I had co-written a paper, I think my first paper was 2014. And that really was more, I had a larger hand in that one. This one, each individual and their own expertise, we kind of divvied it up by subject matter. And we sometimes voluntold individuals who we felt would be the best in the area, that they might really need to provide some input. But some of the key points from this was the importance of a diverse author group, which we had. And it was really wonderful. Michelle Johnston-Fleece, who was at the National Academy of Medicine prior to Anna's position. She had reached out to some of us and had said, are you guys interested in doing a paper on patient and family engagement and equity? So equity was an area we felt that really should be drawn out more, and we are trying to, our premise was that patient and family engagement can promote health equity, and that was tougher than we really realized, because when you write an academic paper, you have to have citations in that work, right? So all of you can really aid in some of this in the future. So the commitment to work over a span of time, as I mentioned, it was really over 2 years. And so there was a lot of waves in our process in this, ups and downs, checking in what's happening. The relationship building is really important. None of us, a few of the people knew each other, but nobody knew everybody, right? And so we were very fortunate to have applied to the Institute for Patient Family Centered Care, the conference that just ended. We applied in 2018 to present there, 6 of us authors, and we did. And so we really had an opportunity there to work on our presentation as well as our paper and get to know each other a little bit better. I was a patient and family advisor on this, and because I have worked, I am in a very diverse community, the Muslim community, and I'm low income, and I've lived in low income housing, and I'm on Medicaid expansion. There was a lot of opportunities that I could share as far as some of the equity, inclusion, and diversity. So agreeing on key definitions was very important, as I mentioned before. And understand, this is probably one of the most important. Everybody is busy, so there's always a bit of we didn't actually poke anybody, but hey, we'd love to hear from you. We haven't quite heard from you in this part of the paper, right? And that went on really, like I said, for the 2 years. So everybody has a life and they have their career, and the writing is something that's generally outside of your work time. And for most patient and family advisors, I mean, we don't get paid for it unless it's part of a project, particularly. So same with most of the the authors, the same. So looking for practical examples of successful patient and family engagement implementation in equity was very difficult. And so really that was one of the most challenging. We found finding either systemic, structural, or organizational opportunities in the different areas of diversity, equity, and inclusion is called out in the paper, and you can look it over and feel free to write to us regarding anything that you find that maybe you have a better example of, because we would love to know, for the patient family partners as well as National Academy of Medicine. So looking to the future, we increased, we're hoping to see increased public recognition of racism as a public health issue and recover from the race-based wrongs. And this is not going to be easy, and it's not just one race, as Naomi had just so astutely mentioned. We are aware of some of the wrongs, and some of the groups or individuals have experienced more so than others, but really overall, there has been a lower amount of representation at all levels in all health systems almost regarding diversity, equity, and inclusion. So, and to ensure that the authentic inclusion, obviously, of impacted communities with a goal for more diversity and equitable systems is really the goal. They could be low income, trans, LGBT, from, individuals who have different experiences with what we might call, either cognitive or physical abilities, skills. So also people always bring their own skills to whatever you write. It's not only their academic, but they might have other knowledge and skills that they are better at, like editing or, looking up, citations. So that's something to always think about. That shouldn't fall on just one person when you're working together as a team. Next slide, please. So this is us, and I did have an okay to post this when we presented at the Institute for Patient and Family Centered Care, as I mentioned, and Michelle Johnson-Fleece is standing up. I'm the one speaking. Kalpana Ramia is one of the leaders of the essential hospitals, which are your trauma hospitals around the United States. Kimberly Dawn Wisdom is in the blue coat, and she's a dynamo equity officer, diversity equity officer at Henry Ford. Next to her, you don't see very well, but Melissa Simon is, OBGYN and brought a lot. She's really the one that pulled the paper together. We tried different individuals pulling the paper together, and the last time she really brought it together and reworked it. And then the individual who's on the far left is Cynthia Bauer, who specializes in English, or literacy. So this was brought up. One of the most biggest issues in this paper was the issue of literacy. English as a second language, understandable materials, and you cannot have equity unless you have that. And so it may be, that the whatever materials your organization is making, please go out to those communities and and bring them in. Like David said, you bring them in, at least be a part of the co-designing of materials to ensure that it really is relevant to the communities that you are working with. And unfortunately, we didn't emphasize telehealth, telemedicine, but we did touch on digital, literacy and some telework. But this has, really expanded during COVID. So it could have, that could be another paper if somebody's interested. So the next slide is our contact information, and if you'd like to put that in, Lindsay, maybe you'd like to route the questions, or?
Yeah. Thank you so much, Janice and Anna. That was just such a such an important piece of health equity, and I know you've worked a really long time on that, so I really appreciate both of you being here to share kind of the information that is in it, and then how folks can really use the document moving forward as well. We do have a couple of questions. I've written some down, but I encourage others. We have plenty of time for questions. I wanted to be sure to leave a lot of time for questions for this particular topic. So please put those in the chat, or you can raise your hand as well, and Laura can tell me if you would like to come off mute for questions. But the first question that I wanted to start with for Naomi, and you briefly touched on this, Naomi, in kind of the invitation that you got to join the work group, but I thought it was important to ask what inside of you made you want to be a part of the diversity, equity, and inclusion work group?
Thank you for that question. It was the thoughtfulness that Libby put out, and the vulnerability. So if you go on the PFCC Partners page, and I think it's on the home page, but just the transparency and the openness of it, and I felt that there was true commitment for change. And so I'm very limited with my time, personal time and work time. And so I pick and choose sparingly. So just based off of of the comments, the commentary, if you will, that PFCC Partners put out about what was going on, and wanting to truly address what can we do, and we are looking internally and being transparent in what was found, and looking at, you know, the makeup of the board. How can we change that? What can we do to be true partners? And I felt that this is a place where I can expend energy and time, and there will be impact. And I think that's one of the questions that somebody had asked, in the sense of the difference between being asked to the table and getting to the table and being able to make differences. And I'll just answer that real quick. In the sense with the DEI group, that was mentioned early on, and there was discussion about, you know, advisors get asked to the tables. There is the ask for inclusion, there is the ask for diversity, but in reality, we really only want one or two to represent. We want tokens, is how it comes across. And part of our discussion in the group was, we don't want to be tokens. We want to be able to truly impact change. What is the outcome after we're at the table and we have these conversations? And part of that conversation turned to, instead of us going to the table, we'll still go, but how do we create the table to invite other people to us?
Yeah, that's a great way to say that, being more inclusive overall. So we're creating that, you guys are creating that table together, so then we can expand those opportunities for partnership. Well said. And Janice, I think you responded to it in the chat box as well, but a similar question as you're an advisor, and this question comes from Ellen Barnett. So did you see in your partnership with the National Academy of Medicine the recognition or the differences among being asked to be at the table, getting to the table, actually being listened to, that your actions or ideas were coming from input, and then follow up to see if those actions were implemented and sustained? Can you talk a little bit about that from your experience?
Sure, thank you. So in this paper, because we had people coming from so many different areas, like a focus on, health literacy, a focus on, running a big hospital, focus on research, focus on, patient and family engagement. I mean, everybody had a different sort of focus. And so really the biggest challenges I heard was just sort of, I wouldn't say it's a challenge, but I'll give you one example, is I really kind of insisted that more than once, it was actually kind of got deleted somehow because we went through so many drafts. And then I said it's very important to call out incarcerated individuals when we're talking about DEI, equity, diversity, equity, and inclusion. So if you don't do anything else, if you look at the first couple paragraphs of the paper, we call out in the introduction some of the areas that some of you have mentioned, but it could be age, geographic location, environmental hazard, literacy, religion. That was where I really felt sexual orientation. I felt it was important to add in incarcerated status. And we had a big discussion about what do we think about incarcerated status. This is what I think. People thought different things. And so that type of thing will go on, and you can be very, headstrong, but you really, you learn to listen to everybody else's thoughts on it and what they know about it, because we all have different knowledge sets. And so that was one of the interesting. So sustaining this, whoever writes a paper similar to this more than likely will use different definitions and they'll use different terminology. This is sort of why this all came about, and some of the terms. When we presented, cultural competency got used, and I used cultural humility or cultural responsiveness. And so it was really hard to kind of pull that together in the paper. But the truth is nobody is culturally competent in all areas. And so I kind of like cultural responsiveness, but it's really a matter of opinion. So when you're working with an organization, you're going to be wrangling with these terms. And it's important that you have a long time to talk about it. So that's the only way everybody kind of gets on the same page, or there's consensus. Mm-hmm. And then there was something else that regarding action. Actually, in the paper, we do, at the end of the paper, there are some sort of action recommendations and some of the best examples. So you can, like, empathy forums, and there's opportunities, birth equity collaborative. So you could look at our paper and see the examples we use are some of the actions that could inform your health system or your organization, how you could go forward. I hope that answers your question.
Yes, thank you, Janice. There was another question from Emily Newberry, who asks, and I'm assuming that this is more for the advisor role, so Naomi or Janice, what are ways that you enlist practitioners, nurses, medical assistants, so healthcare staff, to help find patient partners for initiatives such as this? Emily defines those initiatives as problem-solving teams, co-design, advisory councils, and thinking outside of the box for other opportunities. So I think the question is enlisting healthcare professionals to be a part of that patient partnership. So Naomi, did you have any comments on that?
Yeah, so thinking of the quote by Deborah Perez and talking about inclusion and being able to show what the benefit is as opposed to looking at the flaws. So being able, in healthcare, employees know what we need to fix. And on the other side of that, the patients and the family members know what needs to be fixed. Mm-hmm. Or what are we doing well, and how do we improve? And so it's being able to show how this helps us. How does it they're an extension of our staff. What we think is good for the patient isn't always good for the patient. So looking at whether it's personal experiences from the staff, that helps a lot, because they understand, if they've gone through healthcare with a family member, then they understand from their perspective. Sometimes it's working to get administrators on on board.
Mhm.
And again, it's how does the input from our advisors impact our bottom line? So being able to show what's in it for me. And I can say with our organization, we have advisors, we're involved in every aspect, from policies to putting on hard hats and walking through new construction areas.
That's incredible, Naomi. Thank you for that response. And I totally agree. It's what means the most to those people, the administrators, the medical professionals, and how can we really tap into that. And Naomi, Emily also clarifies that especially maybe partnering with healthcare professionals to help patient family advisory councils or patient family advisory programs find or connect with more diverse populations.
Okay, condense that question. Is the ask, how do you work with, or how do you find diverse populations to work with?
Let me ask Emily, can you come
I
off?
would love to jump in.
Great.
What really particularly worries me is that my impression is that the staff are under a lot of pressure to improve scores on things like Press Ganey and HCAHPS, because that's part of how business decide whether or not to make you one of your options. It's partly because some of the things you get reimbursed for in Medicare and Medicaid depend on those scores. And those, as good as those tests are, those questionnaires are, they don't drill down to, okay, what's happening to your African American patients on these things? And so it's almost like, in spite of people's good intentions, they're under pressure to take care of fixing scores that don't help with diversity and inclusion problems. That's where one of the things I'm struggling with. So how do we show that it's in their interest to help us find the African American patients who are not being well served in diabetes, say, for example?
This is Janice. I'll chime in here a bit. So I serve as an advisor at multiple levels. I know Emily and I serve on a KP National together. And anybody that has been involved, and even they find that there's always an abundance of Caucasian middle-aged people or just retired that are willing to help. And so it really takes time to reach out. But something you brought up is very important, Emily, because anybody that's involved with equity and diversity, and as much as they don't like data, if we don't have the data on the different individuals from the different populations or ethnic groups or age as well as income somewhat, there'll be even a greater disparity can happen, because I call it gets washed out with the sand. I saw this when I first got involved with research. I was like, oh my God, this isn't even broken down. So I want to say that I'm involved with healthcare for the homeless here in Seattle, King County, and this is HRSA, Health Resources Services Administration. And so we actually kind of go above and beyond, and we really do we actually just we asked for it. We wanted to see the demographics of homelessness and individuals with COVID and the outcomes. And they just put together a graph and sent it to us, right? So like the Pacific Islanders and Alaska Native, and I mean, this will be public, but that group, even though it's a small percentage and hasn't always been had a data point, now the federal government is requiring it. So maybe nobody's been doing this for 5 months, but now they're required to. And so, we have been following it, and they had the largest number of COVID exposures or positive, but their deaths weren't as high as, African Americans and even Caucasians, and Latinos were the highest. So it's really important to have that information when you go to your state or county or wherever the federal government, and you say, this is why we need funding. And you talk about equity, everybody's talking about it, but they need to really put their pen to the paper and figure out how they're going to collect data. And part of that should be, as you mentioned, co-design with patients from diverse backgrounds. It's much easier said than done to go and reach out to people, though. You know, if you're in the community, then it's easier. If you're not, then you really have to immerse yourself into the community to have them feel comfortable to be able to share with you.
I'll just add on to that, Janice. In addition to that, I would also say, because we're working to meet a score, to get good scores, where objective should be to give good care and create healthy communities. So when that becomes the focus and we're treating every patient the same way every time with every encounter, then that should be reflected in our scores. So in the sense of, if you have a person, an African American, coming in pain and needing relief, needing medication, instead of going straight to, well, this is a drug seeker, is this a person that is in a sickle cell crisis? Mm-hmm. Right? So it's almost like with school, No Child Left Behind, where teachers are teaching to pass the test as opposed to teaching to educate. The same thing with healthcare. How do we get our communities healthy, and knowing that this, in reaching different groups, people will view me as an angry Black woman. Why? Because I'm assertive? Because I might speak differently? You know, I don't know. So it goes back to looking at what are our biases, how if we can acknowledge what our biases are, if we can check those as we're working with our patients, and then being open to asking them to help us. I will tell you, I became an advisor. The nurse who was helping to take care of my son, we had some very bad experiences, and I was fed up, and I was being seen as the angry Black woman. And I'm okay with that. I don't like the, anyway. But she said, we have a patient advisory council, and if you really want change, I would suggest you talk to them. And so out of negative experiences is how I became an advisor. And so to not be afraid of people who have had negative experiences, because those people can help you reach a population that you can't. Those people can help you change, can help educate staff, can help impact policy, can help you design programs, procedures to where another family doesn't have that same experience.
Absolutely. Thanks, Naomi. And I see Nancy's comment, the concern is how we get from published papers to actual change in the patient experience, which is actually something that we've been talking about a lot in the PFA network, is that I think these published papers and these resources and documents help to provide kind of that framework for folks who don't know where to start and don't really have that insight of what first steps can I take. So I think that that's the next step, is getting this information out there and encouraging folks to take those steps to make actual change. Anna, did you have a comment?
Just wanted to add that this is making me actually think about Naomi's earlier comment about narrative and how we're telling stories. And that ties into something that we were seeing in this paper. There's not a lot of published studies, but we are the National Academy of Medicine. We are within this operating system that values what is published in, ideally, peer-reviewed journal articles. So trying to figure out a way to tell the story in a language that makes sense to the system that we're trying to change. But I agree, it's absolutely the implementation that really needs to happen, and it needs to happen now. That's what we're seeing with COVID. So it's a big question.
Yeah, that's a great
And
point.
I'm glad that you said that, because that's one thing that I didn't mention. When you think about history and medicine and community, African American community, our history is primarily oral history and not written, right? So even thinking 2020, how do you get oral history and can we make that as valid as peer reviewed?
Mm-hmm. Yes, I would love to see that happen. Hopefully our papers are able to incorporate voices in them to make them accessible. We're trying to write for a wider audience, but it's absolutely still a work in progress.
So the first paper I was on in 2014 was with Kaiser. Kaiser Permanente picked it up. It was a PCORI project, and us two patient co-investigators were the two first authors. And so the other patient co-investigator, Michelle, crafted it, and then I did citations and edited it and discussed with her and we worked it out. And then our principal investigator really just added a few comments. And the benefit, and I'll tell you what's super important here, is having a scientific editor. If you have a scientific writer editor, it will make all the difference in the world. She didn't do too much editing, surprisingly, but they're able to share with you how you can better, write the article that will be, then to be peer reviewed. It was peer reviewed, and actually all the papers I think I've been on were peer reviewed, except one maybe. And so it just, once you've written or been a participant in a paper, you'll be asked again, or like I'm starting a new paper right now I reached out to 3 people around the nation on a subject I thought was important, and we're just in initial stages of it. So it's going to just be a commentary, it will be a commentary. If you go for a hard scientific paper, that's a little bit more work. But this is something that we could, have perhaps a class on or something, Lindsay, in the future.
Mm-hmm. Yeah, absolutely. I think there is definitely so much more to come. I see we're at 2 minutes. Sorry, was there one last?
I have a question for the National Academy of Sciences. The qualitative research world is out there, and it's hard to access. It's hard to do simple qualitative research that doesn't take, the same level of rigor that quantitative does. But I think that might be a role for you, is to help us with simple qualitative programs that then could meet the criteria of peer-reviewed research, because there's powerful history to that, and it goes along with stories.
Mm-hmm.
Absolutely, yeah. Thanks so much for that, Ellen. And thank you, everyone. Thank you, Anna and Janice, for representing the National Academy of Medicine. I hope everyone checks out their publication. The link is in the chat, and we will send it out in follow-up. Thank you so much, Naomi, for representing the Diversity, Equity, and Inclusion Work Group. We have a lot more to come over the next however long it takes us with this work group, and we'll definitely keep our community up to date on what is next. But what is next is our now virtual PFCC conference happening on September 21st and 22nd on Zoom. So I asked Laura to put the link to the conference in the chat box so you can access it there. Registration is absolutely free. We really recognize the need for patient family-centered care to happen here and now for everyone. So wanted to open that door for anyone that can participate. We will also be kicking off the conference with a chat with other members of the Diversity, Equity, and Inclusion Work Group to continue this important conversation that will be ongoing for all of us. And with that, if you have any other questions, you can put them in the chat box right now, and I can tap into our presenters over the next week or so to get a follow-up out to you. Also, my email is on the screen now, lindsay@pfccpartners.com. If you have any other questions, please let me know. We have recorded this session and we'll post it to our website in the next week or so. So if there are colleagues that you would like to share this with, it will be available to all of you. So with that, thank you all so much. Hope to see you at the conference next month, and have a wonderful Friday and weekend. Thank you.
Bye-bye. Thank you.
Thanks so much, everyone.